Imagine for a second surviving a grueling, years-long battle with breast cancer.
Right.
You endure the surgeries, the therapies, the exhaustion, and you finally get that clean scan. You're told you are cured.
The ultimate relief.
Exactly. But then, soon after, you realize the very treatment that saved your life has left you in so much chronic, localized pain that you can barely sit down.
Yeah, let alone maintain intimacy.
Right. For up to 75% of breast cancer survivors, the hardest part of their physical journey actually begins after the remission milestone.
It's a staggering statistic, and honestly, it represents a massive blind spot in modern oncology.
Yeah.
I mean, we are currently seeing a 5-year survival rate of up to 90% for breast cancer, which is a monumental triumph of medicine.
Absolutely.
But because the clinical environment is so intensely focused on eradication, on just keeping the cancer away, survivorship quality of life is frequently treated as a secondary concern, or worse, like an acceptable casualty. Women are suffering in silence from these debilitating progressive urogenital symptoms.
Which brings us to the mission of today's deep dive. We are looking at a very specific question that just doesn't get asked enough.
Right.
Can breast cancer treatment affect vaginal tissue strength? And to answer it, we are pulling from a massive stack of sources.
We really are.
We have the latest clinical guidelines from the British Menopause Society, treatment pathways from the Mayo and Cleveland clinics, recent oncology data presented at the 2025 ASCO annual meeting.
Which is huge.
Huge. And crucially, real testimonies from the Breast Cancer Now patient forums. The goal is to give you, the listener, a clear understanding of the mechanics behind these changes, so you know exactly what is happening to the body and, how to advocate for a better quality of life.
Yeah. And to understand why the tissue strength degrades so severely, we really have to look at the biology of estrogen. If you follow reproductive science, you know estrogen regulates the menstrual cycle. But in the urogenital tract, its role is entirely different. It functions as like the primary structural architect of the tissue itself.
So it's essentially the mortar holding the bricks together.
That is a highly accurate way to visualize it, yeah. The vagina, the urethra, the pelvic floor, and a specific area called the bladder trachone are all densely packed with estrogen receptors.
Right.
When estrogen binds to those receptors, it commands the body to maintain tissue thickness. It produces the collagen and elastin that give the vaginal wall its stretch, and it maintains hyaluronic acid to keep the environment hydrated.
Wow, it really does everything down there.
It does. It also regulates the local pH balance by supporting lactobacilli, which are, the good bacteria that fight off infection.
But then a patient undergoes breast cancer treatment.
Right.
And we are talking about systemic interventions here, chemo, pelvic radiation, surgical removal of the ovaries,
Yeah.
or even those long-term endocrine therapies like tamoxifen and aromatase inhibitors. These treatments are designed to drastically reduce estrogen in the body, right?
Exactly. Either by plunging the patient into sudden premature menopause or taking natural menopause and just aggressively accelerating it.
And when that circulating estrogen disappears, the structural architect leaves the building.
Perfect way to put it. The medical term for the resulting condition is genitourinary syndrome of menopause, or GSM.
Okay.
You might also see it in older literature as vulvovaginal atrophy. The physical transformation of the tissue is stark. I mean, without the estrogen to maintain the scaffolding, you lose the superficial epithelial cells.
So the tissue actually changes.
It does. The tissue goes from being thick, pink, and highly elastic to becoming pale, extremely thin, and what we call friable.
Friable meaning it is so fragile, it actually tears under minimal friction.
Yes, the sheer tensile strength of the tissue just plummets. It becomes susceptible to micro tears and bleeding during intercourse,
Garf.
or sometimes just from the friction of walking in certain clothing. And because the tissue is shrinking from lack of blood flow and collagen, the vaginal canal itself can actually shorten and narrow.
You mentioned the bladder trigone earlier. How does that fit into this mechanical breakdown?
Right, so the bladder trigone is a smooth, triangular region at the internal base of the bladder, and it is highly sensitive to estrogen.
Okay.
When it is starved of that hormone, the tissue there also thins out and weakens. And the consequence of that shrinkage is a sudden onset of urinary issues.
Because the barrier is gone.
Exactly. The weakened tissue barrier can't hold back bacteria, leading to recurrent urinary tract infections. And the loss of muscle tone leads to urgency and incontinence.
The interconnectedness of this is devastating. I mean, it's not just about losing sexual function, it's a breakdown of basic daily comfort.
It really is.
Reading through the patient testimonies from the breast cancer, no forum really grounds this in reality. One patient described her experience by saying it felt like her insides had been, quote, sandpapered,
Ugh,
and
yeah.
that there was simply zero stretchiness left. If 3/4 of survivors are feeling like their insides are sandpaper, they aren't just sitting around waiting for the tissue to heal itself.
No, of course not.
They are actively reaching for whatever is on the pharmacy shelf to find relief. But looking at these Mayo Clinic pathways, it seems like the obvious over-the-counter choices might actually be making the situation worse.
They absolutely can, which is why the clinical guidelines draw a really hard line between the different types of non-hormonal over-the-counter products.
Okay.
When a patient is trying to manage this mechanical breakdown, they have to understand the biological difference between vaginal moisturizers and vaginal lubricants
Let me see if I have a mechanism right here, because people use those terms interchangeably all the time.
all the time. Yeah.
A vaginal moisturizer is acting more like a daily face lotion. The goal is to bind to the vaginal epithelium to maintain the skin barrier, restore a bit of elasticity, and balance the pH, completely independent of sexual activity.
Spot on.
Whereas a lubricant is purely a friction reducer. It's like massage oil used strictly for the duration of a specific activity to prevent those friable tissues from tearing.
You've got the distinction perfectly. Moisturizers, like Replens, are designed to be absorbed. They trap whatever local moisture is available and need to be applied regularly, like perhaps 3 times a week, to have any structural benefit.
And the lubricants.
Lubricants are temporary surface-level slicking agents. But here's the critical trap that Sam Evans, the founder of Joe Divine, highlighted in her clinical Q&A.
Oh, yeah.
Many commercial lubricants and moisturizers, even some that doctors blindly recommend, are loaded with additives. Perfumes, dyes, warming agents, and specifically glycerin.
Why is glycerin such a red flag for these patients? I feel like it's in everything.
It is in everything, but glycerin is essentially a sugar byproduct.
Oh, I see where this is going.
Right. Remember how we established that without estrogen, the vaginal pH becomes altered and the protective lactobacilli die off?
Yeah.
If you take a compromised, friable environment that has lost its natural bacterial defenses and you introduce a sugar-based lubricant, you are laying out an all-you-can-eat buffet for yeast.
Oh my God.
It is a direct catalyst for severe thrush and contact dermatitis.
That is infuriating. I mean, a woman experiencing the sandpaper sensation reaches for a product designed to help, and it actively induces a secondary infection.
It happens constantly. Survivors really must check the ingredients for organic, hypoallergenic, water-based, or silicone-based products without glycols or glycerin.
That's a crucial tip for you listening. Check the label.
Yes, and beyond topical applications, the guidelines strongly recommend physical therapies to combat the atrophy.
Like what?
Vaginal dilators are used to gently mechanically stretch the tissue to reverse the narrowing and shortening of the canal.
Because if a muscle or tissue isn't stimulated, the body just lets it atrophy. It's the classic use it or lose it principle, but applied to the vaginal canal.
Correct. Along with pelvic floor exercises, or Kegels. When the estrogen drops, the blood flow to the pelvic region decreases dramatically.
Right.
Kegels force muscle contractions that trigger angiogenesis.
Which is the formation of new blood vessels, right?
Exactly. It draws nutrient-rich blood back into the starving tissue, which also helps reinforce that weakened bladder trigone to combat incontinence.
But looking at all of this, the moisturizers, the dilators, the Kegels, it's clear we're just putting non-hormonal band-aids on a structural deficit.
Yeah, we are.
We are treating the symptoms, but we aren't replacing the mortar between the bricks. Which brings us to the elephant in the room, estrogen.
Here we go.
Since the root cause is a lack of estrogen, the obvious fix is to replace it. But we are talking about women whose breast tumors literally fed on estrogen.
This is the hormonal dilemma that has paralyzed oncology and gynecology for decades.
I can imagine.
To navigate the current science, we have to split hormone therapy into 2 distinct categories. Systemic hormone replacement therapy, or HRT, and local vaginal estrogen.
Okay, let's break those down.
Systemic HRT involves pills or high-dose patches that circulate estrogen throughout the entire bloodstream.
Right.
For women with estrogen receptor-positive breast cancers, systemic HRT is broadly contraindicated.
Which makes sense. You don't want to pour circulating gasoline on a potential microscopic fire somewhere in the body.
Precisely. But local vaginal estrogen is an entirely different delivery mechanism. We are talking about ultra-low-dose creams, tiny tablets like Vagifem or Celastic rings inserted directly into the vagina.
So it stays local.
Exactly. The systemic absorption, meaning the amount that actually escapes the vaginal tissue and enters the main bloodstream, is incredibly minimal.
How minimal are we talking?
Well, to put the math in perspective, using local vaginal estrogen at the recommended clinical dose for an entire year results in the same systemic estrogen exposure as taking one single systemic oral HRT pill.
Wait, let me process that. One pill's worth of estrogen spread out over 365 days.
Yes,
That isn't just low, that's almost a statistical rounding error.
it really is.
But I have to push back here. If the systemic absorption is practically zero, why does the FDA mandate a terrifying black box warning on all vaginal estrogen products, explicitly stating they are contraindicated for breast cancer survivors?
To be fair to the FDA, their historical mandate is to prevent fatal cancer recurrences at all costs. Decades ago, when hormone therapies were being developed, the FDA applied a blanket warning to all estrogen products.
So they didn't differentiate.
No, they didn't. They simply did not have the granular, long-term pharmacological data to prove that local vaginal absorption was negligible enough to be safe. So they defaulted to the safest possible regulatory stance, which was all estrogen is bad for estrogen-positive cancer.
But the consequence of that regulatory lag is immense psychological trauma for the patient.
Huge trauma.
I mean, imagine finally working up the courage to tell your oncologist that you can't be intimate with your partner because of the pain, and they hand you a tube of cream that literally has a black box warning saying it could bring your cancer back.
It creates an agonizing standoff between the patient's fear of recurrence and their daily suffering. But this is exactly where the new data is finally breaking the stalemate.
Let's talk about that data.
At the 2025 ASCO annual meeting, researchers presented findings from a study tracking over 18,000 women.
18,000.
Yes. And another major 2025 review by Best and colleagues analyzed over 24,000 breast cancer survivors.
Wow. Those are massive, highly powered studies. I mean, we aren't looking at small clinical trials anymore.
Not at all. And the findings across these tens of thousands of women were unequivocal.
Which were?
Using low-dose vaginal estrogen does not increase the risk of breast cancer recurrence, and it does not increase breast cancer mortality, even for patients with estrogen receptor-positive tumors.
That's incredible, but I noticed something even more surprising in the Best review notes.
Oh, yeah?
It suggested that some cohorts using vaginal estrogen actually showed better overall survival outcomes. How is that mechanically possible? A localized vaginal cream isn't fighting cancer cells.
No, it's not. It's a brilliant example of secondary clinical effects. It's not that the cream fights cancer. It's that if a woman's debilitating GSM symptoms are effectively managed, she is significantly more likely to adhere to her systemic, life-saving anti-estrogen cancer medication.
Oh, I see.
Yeah, they need to be on those meds for the full 5 to 10 years required. When the urogenital pain becomes unbearable, a massive percentage of women quietly stop taking their cancer drugs.
Which is terrifying.
Right. By treating the pain locally, we remove the barrier to systemic adherence. The cream keeps them on the pill that keeps the cancer away.
That is a profound paradigm shift.
It really is.
But before a listener rushes to their doctor to demand a prescription, the clinical pathways indicate that we have to factor in exactly what kind of cancer drug the patient is taking.
Yes, that is a critical nuance.
The biological math changes depending on the specific systemic therapy. Let's break down the pharmacology of the two main drugs. Tamoxifen versus aromatase inhibitors.
Okay, so this is where the nuance dictates the treatment plan. Tamoxifen belongs to a class of medications called selective estrogen receptor modulators, or SERMs.
Okay.
It works by circulating through the body and actively binding to the estrogen receptors located in the breast tissue. It occupies that space, effectively blocking any circulating estrogen from attaching and feeding the cell.
Wait, so if it's blocking the receptor, is it basically acting like a bouncer at a club?
A bouncer. I like that.
Yeah, like the estrogen might be wandering around the bloodstream, but the tamoxifen bouncer is standing at the door of the breast cell saying, you aren't getting in here.
That is the exact mechanism. And the consequence of that shield is that oncologists generally feel highly confident prescribing vaginal estrogen to patients on tamoxifen.
Because of the bouncer.
Exactly.
Yeah.
Even if a tiny, negligible wisp of estrogen escapes the vagina and enters a bloodstream, the tamoxifen is already standing guard at the breast to block it.
Okay, so tamoxifen provides a bouncer. But what about the aromatase inhibitors? We're talking about drugs like letrozole or anastrozole. How do they handle estrogen?
Aromatase inhibitors, or AIs, function via a completely different pathway. They do not block receptors.
So no bouncers.
No bouncers. Instead, they targeted an enzyme called aromatase, which is responsible for manufacturing estrogen in the body's peripheral tissues, like fat cells and the adrenal glands. AIs shut down that production line, dropping the patient's systemic estrogen levels to near absolute zero.
So instead of hiring a bouncer for the club, aromatase inhibitors just blow up the entire estrogen manufacturing factory.
Biologically speaking, yes. And because there is no bouncer protecting the breast receptor, the breast tissue in a patient on an AI becomes hypersensitive to any circulating estrogen.
Oh, wow.
Yeah, if even a microscopic amount of estrogen from a vaginal cream absorbs into the bloodstream, it could theoretically find an unblocked dormant cancer cell and stimulate it.
That explains why the hesitation still exists among doctors for patients on AIs. You've engineered this pristine zero estrogen environment, and introducing even one pill's worth over a year feels like a risk.
Right.
But what happens to the woman on an AI whose tissue strength has degraded so severely she's getting constant UTIs and the over-the-counter moisturizers aren't working? Is she just out of options?
Yes. Not at all. Modern oncology pathways have developed a very specific strategic workaround for this exact scenario.
Okay, what is it?
If a patient on an AI has severe symptoms, the guidelines suggest consulting their oncologist about temporarily switching their cancer medication from the AI to tamoxifen.
Wait, really? They swap the systemic drug just to treat the local tissue?
Exactly. By bringing in the tamoxifen bouncer, the patient can safely utilize local vaginal estrogen for a few months.
Ah, I see.
The estrogen goes to work rebuilding the structural scaffolding. It restores the collagen, the elasticity, and most importantly, it cornifies the vaginal tissue.
Cornify. What does cornify mean in this context?
Cornification refers to the thickening of the epithelial layers. When the tissue is friable and paper-thin, systemic absorption of the cream is slightly higher because the barrier to the bloodstream is weak.
Right.
But as the estrogen rebuilds and thickens the wall as it cornifies in bad, the tissue becomes robust again, which drastically reduces absorption even further.
That's fascinating.
Yeah, and once the tissue is fully healed and thick, the doctor can stop the estrogen, wait for it to clear, and then switch the patient back to the aromatase inhibitor.
That is an incredibly elegant solution to a complex biological problem. You use the shield to rebuild the wall and then go back to the factory shutdown method.
Which nicely.
Are there any newer pharmaceutical options beyond the creams? I saw osbemifene mentioned in the British Menopause Society notes.
Osbemifene represents the cutting edge of how we manipulate these receptors. It is an oral medication, not a topical cream.
Okay.
It is a SERM, just like tamoxifen, but its pharmacology is highly customized. When osbemifene enters the vaginal tissue, it acts as an estrogen agonist, meaning it mimics estrogen, binding to the local receptors and commanding the tissue to rebuild its strength, moisture, and thickness.
Wow.
But when it circulates to the breast tissue, it acts as an estrogen antagonist, actively blocking the receptors just like a cancer drug would.
That is medical wizardry. I mean, it's programmed to deliver the exact opposite biological instructions depending on which organ it's interacting with. It rebuilds the vagina while starving the breast.
It truly highlights how sophisticated our understanding of targeted pharmacology is becoming.
It's amazing.
Now, osbemifene is generally reserved for patients who have completed their adjuvant cancer therapies, but it proves that we are no longer relying on blunt instruments. We have the technology to address tissue strength without compromising systemic safety.
Which brings us entirely full circle. The overarching question today was whether breast cancer treatments affect vaginal tissue strength, and the answer is a profound yes.
Yes, it is.
By systematically starving the body of estrogen, the structural mortar of the urogenital tract breaks down, leading to thin, friable walls, painful intimacy, and a cascade of urinary issues.
Exactly.
We've explored how to defend that tissue daily with non-hormonal moisturizers while strictly avoiding the glycerin trap, and we've unpacked the massive 2025 ASCO data proving that local vaginal estrogen is a safe, vital tool, especially when managed around the pharmacology of tamoxifen and AIs.
The most important takeaway from all these sources is for you, the listener. If you are navigating breast cancer survivorship, or if you're supporting someone who is, you now have the exact biological vocabulary and the clinical data to take into your next oncology appointment.
Yes, use this information.
You do not have to accept that chronic debilitating tissue pain is the mandatory toll for survival. The safety data exists. the clinical workarounds exist.
Absolutely.
You have the right to advocate for your urogenital health, and you do not have to choose between keeping the cancer away and living a comfortable, functional life.
Advocacy starts with understanding how the machine works. And as we wrap up, I want to leave you with a final, broader idea to ponder.
Let's hear it.
If massive studies are currently proving that we can use ultra-low-dose local hormones to perfectly target and heal specific degraded tissues like rebuilding the structural strength of a vaginal wall without altering the rest of the body or waking up systemic diseases,
Right.
what does this mean for the future of aging? Could microdosing local hormones directly into specific tissues become the ultimate biological hack for extending the health span of all our organs, completely bypassing the systemic risks that have terrified the medical community for decades? It's a fascinating frontier. Thanks for taking this deep dive with us today.